Anterior lamellar keratoplasty involves the selective replacement of diseased corneal stroma to achieve a clear visual axis. In pediatric patients, it is standard practice to perform penetrating keratoplasty for partial thickness corneal opacities resulting from infectious keratitis or trauma. Often, we find penetrating keratoplasty in children to be quite challenging because of their small-sized globe, low corneoscleral rigidity, positive vitreous pressure, and complications following surgery like severe inflammation, secondary glaucoma, immunological graft rejection, suture-related problems, graft infections, and amblyopia due to high astigmatism. As an alternative to penetrating keratoplasty, the DOLC procedure has the advantage of lifetime protection against graft-host dehiscence that eliminates risk of allograft rejection, thereby minimizing risk of graft failure. Another disadvantage of penetrating keratoplasty in children is that the outcomes are abysmally poor compared to those in adults. This is because of the active immune system in children, which leads to a higher incidence of graft rejection, particularly endothelial rejection. On the other hand, DOLC selectively spares the host endothelium, reduces the risk of endothelial rejection, and can be beneficial to at least the subset of pediatric patients who undergo keratoplasty for stromal pathology. A suitable candidate for deep anterior lamellar keratoplasty would be one with a pathology that is confined purely to the stromal layers in the visual axis, such as acquired corneal opacities following infectious keratitis and trauma, or congenital corneal opacities confined to the stroma, including corneal keloids, dermoids, or mucopolysaccharidosis. Preoperative measures. Make sure you include a pediatric anesthetist in your surgical team. Position the child with the head slightly higher to reduce positive pressure. Reduce the intraocular pressure by hyperventilation and use a pediatric speculum to avoid pressure on the globe. Preoperative evaluation. Estimate the visual acuity, density of stromal scarring, and intraocular pressure. Look for nystagmus and posterior segment pathologies, if any, and calculate the axial length measurement and intraocular power. Take a detailed history of the onset and duration of the corneal opacity to help estimate the depth of amblyopia. If the infant is less than a month old, measure the current visual function by assessing the response to light. For an infant aged between 1 and 6 months, measure the current visual function in older infants by checking the fixation to light. In older children, we use teller acuity cards or the preferential looking test. Examine the child either by restraining or by using sedation or anesthesia, using a handheld slit lamp or microscope. Measure the corneal diameter and perform refraction. Measure the intraocular pressure with a handheld tonometer. You will find that older children will usually cooperate in a slit lamp examination. Perform an ultrasound B scan of the eye if you cannot visualize the fundus. Surgical considerations. You must remember that basically pediatric lamellar keratoplasty eliminates the risk of allograft rejection and graft failure. It does not require high-quality donor tissue and one need not wait for donor cornea. It also minimizes any amblyopia. Surgical technique. Carry out the trephination of the host cornea using the desired size of trephine up to the depth of 70 to 80%. Inject air using a bent 26 gauge needle into the deep stromal layers until you achieve the desired big bubble. Air injection is helpful in cases where the pathology extends to the Descemet's membrane level. Deflate the anterior chamber partially through a stab wound. In case you don't achieve a big bubble, then perform the corneal dissection layer by layer or in a spiral manner till you reach the Descemet's membrane. Ensure that the donor tissue is then trephined with a disparity of 0.25 to 0.50 mm and the donor Descemet's membrane is peeled off after staining with trypan blue dye. Suture the graft to the host bed using 16 interrupted 10-0 monofilament nylon sutures or combined interrupted and continuous 10-0 monofilament nylon sutures. Fill the chamber 2/3 with sterile air. Finally, ensure that the graft-host junction is well opposed. Children are more likely to injure themselves during play, which could lead to their experiencing higher rates of post-surgery complications. These complications could include Descemet's separation, double anterior chamber, pupillary block glaucoma, or necessitate reoperations such as descemetopexy or cataract extraction or regrafting. Procedures such as synecholysis, pupilloplasty, or peripheral iridectomy too may be required. It is important to educate the parents of the child on post-surgery care, informing them about the warning signs to watch out for, the method of instilling eye medications, and the importance of frequent examination under anesthesia in the first year following surgery to check for refraction, intraocular pressure, and fundus evaluation. Advice on periodic change of glasses and appropriate patching as required. The visual outcome in pediatric deep anterior lamellar keratoplasty is quite encouraging. Mainly, we do not disturb globe integrity, facilitate early visual rehabilitation, and also eliminate risk of allograft graft rejection. How well the child will be able to see depends on the age of onset of the corneal pathology and its causes, laterality, type of optical rehabilitation, amblyopia therapy being administered, and the extent of post-surgery complications. You are now familiar with the indications and surgical technique for pediatric lamellar keratoplasty, the differences between adult and pediatric grafts, the pre-operative evaluation procedure, and the follow-up requirements after surgery.